Ever get that feeling? You know, like you're missing some crucial piece of the puzzle when it comes to your health.
Yeah.
Well, today we're tackling one of those pieces. We're going a deep dive into blood pressure and hypertension, going way beyond just like, basic checkups. And huge thanks to London Heartbeat Z Academy, by the way, for giving us this super detailed medical guide.
Yeah, it's awesome. It's like we're getting a sneak peek behind the curtain. Like, this is the stuff that doctors usually keep to themselves.
Insider knowledge, just for our listeners.
Yeah.
And speaking of insights, this guide jumps right in with something interesting. A new blood pressure category. Elevated blood pressure.
Yeah, it's like they're saying, hey, even slightly elevated numbers, you can't just ignore those.
Right, a heads up, like a yellow light. This deep dive, it's about more than just understanding high blood pressure. It's about recognizing those early signs, taking steps, being proactive.
Exactly.
Before things even get to, like, full-blown hypertension.
Yeah, exactly. And it's not just a random category either. Like, there's a reason for this. Even a little bit of elevated blood pressure, it increases your risk for, cardiovascular disease later on. So maybe, I don't know, doctors might start recommending lifestyle changes sooner.
Prevention is key. The guide goes on to lay out all the different blood pressure categories, from like optimal to normal to high normal, and then grades 1 through 3 hypertension. It's a roadmap, really helps you understand where your numbers fit in, what they actually mean.
And speaking of understanding where you stand, we have to talk about the different ways to actually measure blood pressure.
Yeah, right.
The guide, it highlights 3 main approaches: office, ambulatory, and then home monitoring.
Like having the right tool for the job.
Yeah.
We're all used to that classic blood pressure check at the doctor's office, but as the guide points out, it's not always perfect. White coat hypertension.
Yeah. Oh, yeah, classic. Like your blood pressure shoots up just because you're at the doctor, nervous.
Gracious.
Exactly. And that's where ambulatory blood pressure monitoring, or ABPM, comes in. Imagine this: a 247 blood pressure detective, basically, monitoring your readings all day long.
Wow, that'd be intense. So ABPM, it gives you like a much more complete picture, right? Not just one point in time.
Way more accurate. And it helps with what's called masked hypertension. Your readings at the doctor look fine, but then outside, they're actually high.
So sneaky. It's like hidden hypertension.
Exactly. And the guide actually has a handy table, breaks down all the different methods, pros and cons of each, really makes it clear that ABPM is, like, the gold standard.
But wait, don't discount home blood pressure monitoring just yet.
Yeah.
This is where you take control, become your own advocate for your health.
Right, exactly. You're in the driver's seat.
Home blood pressure monitoring, HBPM,
Right.
lets you check those readings at home whenever. You get a sense of control, stay more engaged. Okay, so we've talked about what hypertension is, but let's get into the WHY. The guide gets into, I don't know if I can say this word, pathophysiology. It sounds intimidating, but it's basically explaining what's happening inside your body to cause high blood pressure.
Think of it as like the behind-the-scenes action of a movie. All these intricate things going on, affecting your blood pressure.
Intricate is right. The guide breaks it down into 6 key mechanisms that contribute to high blood pressure, starting with, and this one is a mouthful, the sympathetic nervous system.
Right, so that's your body's fight or flight response, right? It's supposed to kick in when you're facing danger, but when it's constantly overactive, it can cause your blood pressure to stay high, chronically. Like your body is stuck in overdrive, even when there's no need to be speeding.
Exhausting. And not good for your heart and blood vessels, I imagine.
Not at all. Now, another key player in this whole blood pressure drama is the renin-angiotensin-aldosterone system, or RAAS for short.
Ah, yes, the RAAS.
This system is all about regulating blood pressure, but when it's out of whack, it can contribute to, sustained hypertension and even damage your organs over time.
The guide mentions the heart, kidneys, and blood vessels are particularly vulnerable to damage from an out-of-control RAAS. It makes it clear that this isn't something to take lightly.
Not at all. Now, then there's endothelial dysfunction.
Endothelial dysfunction. Okay.
Think of the endothelium as the delicate lining of your blood vessels, okay? Really important for regulating blood flow. But with hypertension, this lining gets damaged. It can't produce nitric oxide as well, which is a natural vasodilator. So your blood vessels constrict more, there's more resistance.
Kind of like a clogged pipe, making it harder for things to flow through.
Yeah, a perfect analogy. And that's how you get atherosclerosis, that plaque buildup in the arteries. Heart attacks, strokes, the whole 9 yards.
Scary stuff.
Yeah.
And the guide also points out that genetics plays a role in all of this. Like hypertension tends to run in families, and researchers are finding specific genes that make you more prone to high blood pressure.
Yep. So some people are dealt a tougher hand genetically, but that doesn't mean you're helpless.
Right. It's about understanding your risks and taking the steps you can control. The guide also dives into the kidneys and their role in regulating blood pressure.
Oh yeah, the kidneys, think of them like filters, right? Cleaning your blood, controlling fluid.
But when they're not working properly, it can actually contribute to hypertension.
Yeah, it becomes a vicious cycle. Bad kidneys, high blood pressure, worse kidneys.
Not a cycle you want to get stuck in.
Definitely not.
And then the guide talks about vascular remodeling. It's a process where chronic hypertension actually changes the structure of your blood vessels.
Yeah, it's wild, like a garden hose, losing its flexibility. They thicken, become less elastic.
So then your heart has to work harder to pump blood through. And that, of course, just makes the hypertension worse.
Exactly. It's a classic example of how uncontrolled high blood pressure just makes the problem worse over time.
So we've got these 6 intricate mechanisms, all working behind the scenes, influencing blood pressure. But good news, the guide doesn't just leave us there. It also dives into the risk factors, things that increase your chances of developing hypertension, both things you can change and things you can't.
Right. So first, the things you can't change. Age, gender, genetics, your ethnicity. We can't turn back time, right? But knowing these factors helps you understand your baseline risk.
Right. It's like knowing the terrain before you start your journey.
Exactly. Now, on to the things you can control, and this is where it gets empowering, because you can actually do something about these. The guide lists diet, physical inactivity, obesity, alcohol, smoking, stress, and sleep apnea as the main culprits.
And each of these factors contributes in its own way. Like a diet high in sodium, that can disrupt fluid balance, increase blood pressure.
Yeah, and if you're not physically active, well, that increases your risk for obesity, weakens your heart and blood vessels, so they can't regulate blood pressure as well.
Right, it all ties together.
It does. It does. And what I love about the guide is that it emphasizes that even small changes can make a big difference, like just swapping processed foods for fresh fruits and veggies, or finding ways to get, 30 minutes of exercise a day, most days. Learning how to manage stress better. These things can have a huge impact.
It's those everyday choices that really add up.
Exactly. And of course, we can't forget about smoking and excessive alcohol. Smoking, it damages your blood vessels, increases your risk of heart disease. And heavy drinking, well, that directly raises your blood pressure.
So if you're serious about getting your blood pressure under control, those are definitely things to address. Now, remember that 247 blood pressure detective we talked about earlier, the ABPM.
Yeah, I love that analogy.
The guide has a whole section dedicated to it, really emphasizing its importance, not just for diagnosing hypertension, but also for really understanding how your blood pressure fluctuates throughout the day.
It gives you that granular detail, way more than just a single reading at the doctor's office. And it can catch those tricky cases, the white coat hypertension, the masked hypertension, things that might otherwise slip through the cracks.
It's like having a constant stream of data.
Exactly. And it also gives you information about your nocturnal blood pressure. That's your blood pressure while you're asleep. Ideally, it should dip at night, when you're resting.
Makes sense.
But for some people, it stays high or even goes up, and that's a red flag. Non-dipping, or reverse dipping, it's called. It means you're at a higher risk for heart problems.
So ABPM is not just about diagnosis. It's about getting a complete picture of your cardiovascular health.
Yeah.
Your risk profile.
Absolutely. A whole lot more than just a number on a screen.
And speaking of taking control, we have to talk about home blood pressure monitoring. HBPM. This is where you get to monitor your own blood pressure right at home.
You become an active participant in your health.
Exactly. You get to see how your lifestyle changes or medications are affecting your numbers. You track your progress. It's empowering.
Absolutely. And the guide even points out that it can potentially save you money, fewer trips to the doctor.
Proactive healthcare.
Exactly.
All right, let's dive a bit deeper into those dipping patterns we mentioned. How blood pressure ideally should dip at night. The guide explains there are 3 main patterns: normal dipping, non-dipping, and reverse dipping.
Yeah, so with normal dipping, your blood pressure goes down nicely at night, lowest risk. But if you're a non-dipper, it doesn't drop enough, higher risk.
And reverse dipping, well, that's when your blood pressure actually goes up at night, highest risk.
Yep. So these dipping patterns, they go beyond just the numbers. They tell you about your overall health, your risk.
It's like a hidden message, even if your daytime readings look okay.
Exactly. And this information can really help guide treatment decisions. Like someone with reverse dipping, they might need more aggressive treatment, even if their daytime readings are the same as someone with normal dipping.
It's about individualizing the treatment plan.
Absolutely.
All right, buckle up. because we're about to enter the world of secondary hypertension. Imagine this. You go to the doctor, blood pressure is high. You start making changes, maybe even medication, but the numbers won't budge.
Frustrating, right?
Totally. And that's where secondary hypertension comes in. It's like your high blood pressure is a clue pointing to another problem, another underlying condition.
So it's not the main problem, it's secondary to something else.
And the guide, it gives this whole list of potential culprits: kidney issues, hormonal disorders, sleep problems, problems with your blood vessels, even medication side effects.
It's a medical detective story for sure.
Right. And the key is to find that root cause, treat that, not just the blood pressure itself.
Exactly. Let's dig into some of these common suspects. Starting with the kidneys. Chronic kidney disease, that's a big one. The kidneys can't filter waste properly.
And since the kidneys are involved in regulating blood pressure, well, it makes sense that problems there would lead to hypertension.
Totally. The guide also mentions renovascular hypertension. That's when the arteries that supply blood to the kidneys, they get narrow, restricts blood flow, blood pressure goes up.
Like a kink in a hose.
Yeah, good analogy. And then there's polycystic kidney disease. That's a genetic condition where cysts grow in the kidneys, mess up their function.
Lots of ways the kidneys can get involved.
Yep. Now let's talk about endocrine causes, those hormonal ones. The guide points out primary aldosteronism. That's when your adrenal glands produce too much aldosterone. That's a hormone that regulates salt and water balance.
Too much aldosterone, you retain too much sodium, lose potassium, blood pressure goes up.
Exactly, like your hormones are throwing off the whole balance. The guide also mentions Cushing's syndrome. Too much cortisol, that's a stress hormone, that can also raise blood pressure.
Stress, hormones, blood pressure, it's all connected.
Big time. And then there's this rare one, pheochromocytoma. It's a tumor of the adrenal glands that releases these hormones, catecholamines. They can cause sudden, massive spikes in blood pressure.
Yikes.
Yeah.
That sounds pretty intense.
It can be. The guide even lists thyroid disorders, too. Both an overactive thyroid, hyperthyroidism, and an underactive thyroid, hypothyroidism, can affect blood pressure.
It's incredible how many different things can impact blood pressure. It really shows how interconnected all the systems in our body are.
Right. Now, we can't forget about sleep. Obstructive sleep apnea, OSA. That's when your breathing repeatedly stops and starts while you're asleep. Disrupts your sleep, lowers your oxygen levels, throws your stress hormones out of whack.
So it's not just about how as you sleep, it's about how well you sleep.
Exactly. Quality over quantity.
All right, moving on to vascular causes. Problems with the blood vessels themselves. The guide mentions coarctation of the aorta. That's a birth defect, where the aorta, that's the main artery carrying blood from the heart, is narrowed.
So it restricts blood flow, can lead to high blood pressure, especially in the upper body, like a bottleneck on a highway.
Makes sense.
And then there's medication-induced hypertension. Basically, some medications can have the side effect of raising your blood pressure.
Oh, wow, that's something to be aware of.
Definitely. The guide lists a whole bunch of culprits, things like NSAIDs, those are pain relievers, corticosteroids, birth control pills, even some antidepressants.
Always a good idea to read those medication labels. Talk to your doctor about any concerns.
Absolutely. Now, the guide also mentions a few other factors that can contribute to secondary hypertension. Alcohol, for one. We already talked about it, but it's worth repeating. Chronic heavy drinking can make things much worse.
Makes sense. And what about obesity and metabolic syndrome? We talked about those as risk factors for primary hypertension, but can they play a role in secondary hypertension as well?
They can, especially when they're combined with other things like sleep apnea or insulin resistance.
It's like a whole web of interconnected factors.
It really is.
So if someone thinks their high blood pressure might be due to another medical condition, what should they do? What are some signs to look out for?
The guide has some helpful tips there. Like if you have severe hypertension or resistant hypertension, that's when it's really high or hard to control with meds. That's a red flag.
Right. That makes sense.
Also, if your hypertension comes on suddenly, especially if you're young or over 50 and haven't had high blood pressure before, that's worth checking out.
It's like your body's sending you a message, hey, something's not right here.
Exactly. And then there are symptoms that are specific to certain underlying conditions. Like if you have primary aldosteronism, you might get muscle weakness or fatigue. Or with pheochromocytoma, you might have episodes of sweating, heart palpitations, or really bad headaches.
So it's about paying attention to your body's signals.
Absolutely. Don't just brush things off as getting older. Those symptoms could be giving you valuable clues.
You're your own health detective. Now, if secondary hypertension is suspected, the next step is to figure out what's causing it. The guide outlines a whole process, starting with, a good old-fashioned history and physical exam. The doctor's going to ask about your medical history, your family history, your lifestyle. They'll check your blood pressure, listen to your heart and lungs.
Gather all the clues, right?
Yeah, exactly. And then it's time for lab tests and imaging. The specific tests will depend on what the doctor suspects, but blood tests are common. Check your kidney function, electrolytes, hormone levels.
Right. And urine tests. Looking for protein, that can be a sign of kidney damage. Or checking for high levels of certain hormones.
And imaging.
Yep. Ultrasounds, CT scans, MRIs. They give you detailed pictures of the kidneys, adrenal glands, blood vessels, so you can see if there are any structural problems.
Like a tumor or something like that.
Exactly. And if sleep apnea is suspected, well, they might do a sleep study, monitor your breathing, your oxygen levels while you're asleep.
So many ways to gather information. The goal is to really pinpoint that underlying cause.
Yeah.
And once you know what it is, then you can treat that root problem.
Right, instead of just chasing the symptom. Let's look at a few examples. If the cause is chronic kidney disease, then treatment will focus on protecting the kidneys. They might use medications like ACE inhibitors or ARBs, which not only lower blood pressure, but also have kidney protective effects.
Two birds with one stone. What about if it's renovascular hypertension?
That one, they might do procedures like angioplasty or stenting to open up those narrowed arteries.
Open up the blockage, get the blood flowing properly again?
Exactly. And of course, they'll use medications to manage the blood pressure as well. Now, if it's an endocrine disorder, like primary aldosteronism, they might actually do surgery, remove the adrenal adenoma that's producing all that extra aldosterone.
Makes sense. Get rid of the source of the problem.
Yep. Or they could use medications called aldosterone antagonists, things like spironolactone. They block the effects of the excess aldosterone.
And we talked about sleep apnea earlier. Treating that with CPAP therapy can really improve blood pressure.
Yeah, definitely. And with coarctation of the aorta, remember that birth defect with the narrowed aorta. They usually do surgery for that too.
Yeah.
Widen that narrowed section, restore normal blood flow.
Fix it at the source.
Yep. And for medication-induced hypertension, well, the most straightforward solution is to stop taking the offending medication or switch to something else.
Right. Of course, always talk to your doctor before making any changes to your medications.
Absolutely.
So the bottom line is a secondary hypertension. You can't just treat the high blood pressure. You got to find and treat that root cause.
It's like imagine trying to bail out a boat, but there's a hole in the bottom. You've got to fix that hole.
Exactly. Okay, let's shift gears a bit. Talk about a type of hypertension that can be super tricky to manage. Resistant hypertension. That's when your blood pressure stays high, even though you're on like 3 or more different medications, including a diuretic.
It's like your body's just not responding to the usual treatments.
Yeah. And the guide, it stresses how important it is to rule out pseudo-resistance. So basically, making sure it's actually resistance to the meds and not something else entirely.
Right, you don't want to be barking up the wrong tree. Things like, oh, maybe you're not taking your medications right, or you're getting inaccurate blood pressure readings, or you're just on the wrong combo of drugs.
So it's detective work again. Got to find the real culprit. And once you've confirmed it's truly resistant hypertension, then you've got to figure out what's causing it, which could be a bunch of things, like lifestyle factors, secondary hypertension, even medication interactions.
Right, lots of possibilities. And the guide goes into all sorts of management strategies. It emphasizes a multi-pronged approach. So optimizing your meds, addressing lifestyle stuff, and in some cases, even considering those device-based interventions.
So lots of tools in the toolbox.
Exactly.
Okay, now hold on tight because we're going even deeper into the world of refractory hypertension. This is like the boss level of resistant hypertension. We're talking blood pressure that's still uncontrolled even after trying 5 or more different medications.
Yeah, this is when it gets really tough. Your body's basically put up a wall, and it's super hard to get that blood pressure down.
And the guide, it makes it clear that refractory hypertension is linked to a way higher risk of, heart attacks, strokes, all those serious complications.
Definitely. And one theory is that it's all about an overactive sympathetic nervous system. Remember, that's the fight or flight system. When it's constantly in overdrive, it can make your blood pressure incredibly hard to control.
So refractory hypertension is a tough nut to crack.
Yeah.
But the guide, it doesn't leave us hanging. It lays out a whole approach to evaluating, diagnosing, and managing it.
It's all about gathering information, figuring out what's contributing to the problem, and then coming up with a plan that really addresses the individual's specific needs. Like, you might need to tweak the medications even more, really focus on lifestyle changes that calm down that sympathetic nervous system. And in some cases, you might even consider those device-based interventions.
Those sound pretty high-tech. What are they exactly?
Think of them as like really targeted ways to control that overactive sympathetic nervous system. So one example is renal denervation. It's a procedure that uses radiofrequency energy to disrupt the nerves around the renal arteries.
Wow, that's intense.
Right. And then there's baroreceptor activation therapy. They implant a device that stimulates the baroreceptors, those are pressure sensors, in your carotid arteries. And that sends signals to your brain to help lower your blood pressure.
So it's like hacking into your body's control system.
Pretty much. And these therapies, they're not usually the first line of treatment, but they do offer hope for people with refractory hypertension who haven't responded to anything else.
So there's always hope.
Always.
All right, we've covered a lot of ground, from the basics of hypertension to the really complex stuff. But there's one more piece of the puzzle we need to talk about. Medication.
Ah, yes. The world of pharmacology.
Yeah.
All those different drugs that can help control blood pressure.
Exactly. And the guide goes through all the main classes of antihypertensive meds, starting with those first-line agents we keep mentioning, the ACE inhibitors, ARBs, CCBs, and thiazide diuretics.
Right, those are the heavy hitters. Usually the first ones doctors prescribe to get that blood pressure down.
And they all work a little differently.
Right. Oh, yeah. They each have their own mechanism of action, their own way of targeting those blood pressure control systems.
So it's not one size fits all.
Nope, not at all. So, for example, ACE inhibitors and ARBs, those work on the RAS, that renin-angiotensin-aldosterone system we talked about before.
Yes, the RAS, that complex hormonal system that can really mess with your blood pressure.
Exactly. So ACE inhibitors and ARBs, they block different parts of that system, which helps relax the blood vessels, get rid of excess fluid, and ultimately bring that blood pressure down.
Makes sense. And then there are the CCBs, calcium channel blockers. I know they block calcium channels, but how does that help with blood pressure?
Okay, so calcium is really important for muscle contraction, right? Including the muscles in your blood vessel walls.
Yeah.
So by blocking those calcium channels, CCBs keep those blood vessels from constricting, they relax, they open up, blood flows easier, pressure goes down.
It's like loosening a tight belt.
Exactly. And then we have the thiazide diuretics. They work on your kidneys, help your body get rid of extra salt and water.
So less fluid in your blood vessels, lower blood pressure.
Yep. It's like draining some water out of a pool to reduce the pressure.
Perfect analogy. Okay, so with all these different options, how do doctors decide which one to start with?
That's the million-dollar question, right? And unfortunately, there's no easy answer. It really depends on the individual, their blood pressure level, other health conditions, what side effects they might experience, even cost.
So it's personalized medicine.
It is. It's about looking at the whole picture. So, for example, if someone has diabetes, a doctor might choose an ACE inhibitor or an ARB first, because those meds not only lower blood pressure, but they also protect the kidneys.
Which is especially important for people with diabetes, right?
Exactly. And cost, yeah, that's definitely a factor too. Thankfully, a lot of these blood pressure medications are available as generics, which are usually much cheaper.
So there are options.
There are. And the guide really encourages people to talk to their doctor about cost concerns. Find a plan that works for their health A&D, their budget.
Right. It's a team effort. Now, we've been talking about these first-line agents, but sometimes those aren't enough, or maybe someone has a condition that makes a different medication a better choice. That's when those second-line and add-on agents come into play.
Exactly. It's like having a backup plan.
What are some of those second-line and add-on meds?
Well, there are beta blockers. Those are often used for heart conditions, but they can lower blood pressure too. And then MRAs, we talked about those in the context of resistant hypertension. And then there's a whole group called other agents, which includes alpha blockers, centrally acting agents, and direct vasodilators.
Okay, let's break those down a bit. Beta blockers, they work by blocking the effects of adrenaline, right?
Yep. Adrenaline makes your heart beat faster and harder, raises your blood pressure. So by blocking those effects, beta blockers help slow the heart down, reduce its workload, and ultimately lower blood pressure. They're especially helpful for people with heart disease because they can protect the heart from further damage.
So they're good for the heart in multiple ways.
Exactly. Now, MRAs, we already talked about those. They help balance electrolytes, get rid of excess fluid. They can be really helpful when other meds aren't doing the trick.
Okay, and what about those other agents?
So alpha blockers, they relax certain muscles and help keep those small blood vessels open, reduces resistance to blood flow. Centrally acting agents work in the brain, reducing nerve signals that constrict blood vessels. And direct vasodilators, well, they do exactly what their name suggests. Directly relax and widen the blood vessels.
So they all have their own unique ways of lowering blood pressure.
They do. It's like having a whole arsenal of weapons to fight hypertension.
Now, the guide also talks about combination therapy, using 2 or more medications together.
Right. It might seem counterintuitive, like, why take more pills? But sometimes using lower doses of 2 medications can actually work better and cause fewer side effects than a higher dose of just one drug.
So it's about finding the right synergy.
Exactly. And there are a few combinations that are really common and effective, like an ACE inhibitor or ARB with a CCB, or an ACE inhibitor or ARB with a thiazide diuretic.
Okay, so when it comes to medications, the goal is to lower blood pressure, obviously, but are there specific targets? Like what numbers are doctors aiming for?
The guide follows the current guidelines, which recommend getting your blood pressure below 40/80. For most people, anyway.
But there are exceptions.
There are. Like for older folks, those 65 and up, sometimes a slightly higher target is okay, like 130 to 139 over 70 to 79. If they can tolerate it well, that is, because pushing blood pressure too low in older adults can actually be dangerous, cause dizziness, falls, things like that.
So it's a balancing act.
It is. And then for people who are at higher risk for complications, like those with diabetes or chronic kidney disease, those lower targets might be even more important.
Because you want to protect those organs.
Exactly. It's all about tailoring the treatment to the individual.
Now, what about resistant hypertension? What's the plan when those meds just aren't bringing the numbers down?
Well, first, like we said before, rule out pseudo-resistance. Make sure it's the real deal. Then, really focus on lifestyle changes. Things like the DHH diet, cutting back on salt, losing weight if you need to, getting regular exercise. Those are always important, but even more so when your blood pressure is being stubborn.
Laying a strong foundation.
Exactly. And then it's about tweaking those medication regimens. You might need to add a 4th drug, like an MRA, spironolactone. That can be really helpful in resistant hypertension.
And the guide, it considers that a pretty strong recommendation, right?
Yeah, class Dayburit means there's good evidence to back it up. But if MRAs aren't an option, maybe because of side effects or other medical issues, then you might look at alpha blockers or centrally acting agents. But those are weaker recommendations, class IB.
So more of a last resort.
Kind of. And in really tough cases of resistant hypertension, the guide recommends getting a referral to a specialist.
Someone who really knows their stuff.
Exactly. Now, the guide also has specific advice for certain groups, people with diabetes, chronic kidney disease, older folks, pregnant women.
Let's start with diabetes. What are the big takeaways there?
Well, ACE inhibitors, or ARBs, those are the preferred first-line meds for folks with diabetes because they not only lower blood pressure, but they also protect the kidneys.
Which is huge for people with diabetes. They're already at higher risk for kidney problems.
Exactly. And the blood pressure target is the same, less than 13/80. But again, it's important to be careful about going too low, because that can actually increase the risk of some complications in people with diabetes.
It's all about finding that balance.
It is. Now, with chronic kidney disease, ACE inhibitors or ARBs, they're the top picks there too, especially for folks who have proteinuria.
Right, that's a sign of kidney damage. And those meds help slow down the progression of that damage.
Yep. And the blood pressure target is the same, less than 13/80. But again, got to be careful not to go too low.
What about older adults? Any special considerations for them?
Yeah, the guide really emphasizes that blood pressure targets need to be individualized for older folks. So you got to factor in their overall health, how frail they are, how well they tolerate medications.
So that 30/80 target might be good for some, but others might need to aim a bit higher.
Exactly. You don't want to cause more harm than good. And when it comes to meds, the guide recommends starting low and going slow.
Because older adults are more sensitive to medication side effects.
Exactly.
Now, pregnancy. We've already talked a lot about how important it is to manage blood pressure carefully during pregnancy, but are there any specific medications that are recommended?
The big thing here is choosing meds that are safe for both the mother and the baby. Some blood pressure medications can actually cross the placenta and harm the fetus.
So what should pregnant women avoid?
Definitely ACE inhibitors, ARBs, and direct renin inhibitors. Those can interfere with fetal development, especially the kidneys.
Not good. So what are the safe options?
The guide mentions a few: labetalol, methyl-dopa, and nifedipine. Those have a good track record of being safe and effective during pregnancy.
Okay, good to know. And of course, close monitoring is essential throughout pregnancy.
Yeah.
Make sure the blood pressure is under control and that both mom and baby are doing well.
Absolutely. Now, last but not least, let's revisit hypertensive crisis. Those situations where blood pressure goes sky high and you need to act fast.
Right. We talked about the two types: hypertensive emergency, where there's organ damage, and hypertensive urgency, where there's not. And the guide gives specific recommendations for each one.
Yep. For hypertensive emergencies, it's all about getting that blood pressure down ASAP, using intravenous meds, usually in the ICU.
And the guide has specific targets for how much to lower the pressure and how quickly.
Right. It's a delicate balance. You got to bring it down fast enough to prevent more damage, but not so fast that you cut off blood flow to vital organs.
And what about hypertensive urgency?
That one, you can usually manage it with oral meds, bringing the blood pressure down gradually over a day or two. You don't usually need to go to the hospital right away, but you do need to see a doctor ASAP and get things under control.
Okay, so both types are serious, but the level of urgency is different. Now, the guide also talks about all the different things that can trigger a hypertensive crisis. What are some of those culprits?
One of the most common is just not taking your meds as prescribed, skipping doses or stopping altogether. That can cause a dangerous rebound effect.
Right, your blood pressure shoots right back up.
Exactly. And then there are underlying medical conditions, things like chronic kidney disease, that pheochromocytoma we talked about earlier, other hormonal disorders. They can all throw off your blood pressure control system and make you more likely to have a sudden spike.
So it's like those conditions are ticking time bombs.
Kind of, yeah. And then there's substance use, things like cocaine and amphetamines.
Powerful stimulants. I can see how those would send your blood pressure through the roof.
Yep. And even excessive alcohol. A little bit might be okay for some people, but binge drinking or chronic heavy drinking, that can definitely lead to big fluctuations in blood pressure.
So moderation is key.
Absolutely. And then here's something that's important to remember. Things like strokes and heart attacks, they can both trigger a hypertensive crisis A&D result from one.
It's a vicious cycle.
It can be. The high blood pressure makes those conditions worse, and then those conditions make the blood pressure worse. So it's really important to get prompt and comprehensive medical care if any of those things happen.
It's a team effort. All right, let's focus on pregnant women for a bit.
Hypertension in pregnancy, it's a big deal. It can affect both mom and baby. The guide actually breaks down the different types of hypertension you can get during pregnancy.
Right, we talked about those earlier.
Yeah.
Chronic hypertension, gestational hypertension, preeclampsia, eclampsia.
Exactly. And it's important to understand the differences because they have different implications for treatment and risk. So chronic hypertension is high blood pressure that's already there before pregnancy or diagnosed before 20 weeks.
Okay. And gestational hypertension, that's high blood pressure that develops after 20 weeks, but without any other signs of problems, like protein in the urine.
Right. And then preeclampsia, that's when you get high blood pressure after 20 weeks. But you also have signs of organ damage, usually the kidneys or the liver.
And eclampsia, that's the most severe form: high blood pressure, organ damage, and seizures.
Exactly. That one's a real medical emergency. The guide does a good job of explaining the risks that come with each type of hypertension in pregnancy, for both mom and baby.
Like for moms, it can increase the risk of stroke, heart problems, kidney problems, placental abruption, and of course, eclampsia.
And for babies, it can lead to growth restriction, preterm birth, low birth weight, even stillbirth in severe cases.
So it's really important to keep that blood pressure under control. What about managing hypertension during pregnancy? What are the recommendations?
Well, first, you got to set appropriate blood pressure targets. For mild hypertension, the goal is usually to keep it below 14/90. But for severe hypertension, that's when it's 160 or 110 or higher, you need to be more aggressive with treatment.
Because the stakes are higher.
Exactly. Now, when it comes to meds, it's really important to choose ones that are safe for the baby. Some blood pressure medications can cross the placenta and cause harm.
So what are the safe options?
The guide lists labetalol, methyl-dopa, and nifedipine. Those have a good track record of being safe and effective during pregnancy.
Good to know. And I'm guessing close monitoring is key.
Oh, absolutely. Regular prenatal visits, blood pressure checks, urine tests to monitor for protein, all that good stuff.
Now, what about preeclampsia specifically? How do they manage that?
It depends on how severe it is. For mild preeclampsia, they might just monitor closely, recommend bed rest, and maybe prescribe meds to lower blood pressure and prevent seizures.
So a more conservative approach at first.
Right. But for severe preeclampsia, that usually means hospitalization. And they often use magnesium sulfate, given through an IV, to prevent seizures and other complications.
And when those seizures actually happen, that's when it becomes eclampsia.
Yep, that's a true emergency. The guide stresses that you got to act fast, control the seizures, lower the blood pressure, stabilize the mom, and often they have to deliver the baby right away, even if it's premature.
Wow. So much to think about.
There is. And here's something else to remember. Even after the baby is born, blood pressure often stays elevated for a while. So you might need ongoing monitoring and medication.
So it's not just a pregnancy issue, it can linger.
It can. And the guide also points out that women who've had hypertension during pregnancy, they're at higher risk for heart problems later in life. So long-term follow-up is important.
It's like pregnancy gives you a glimpse into your future health.
Kind of, yeah. Okay, let's shift gears a bit and talk about some of the research that's been done on hypertension. The guide highlights 10 key clinical trials that have really helped us understand this condition.
Real game changers.
For sure. Like the SPRINT trial, that showed that aiming for a lower blood pressure target, less than 12/20/80, could really reduce the risk of heart attacks, strokes, even death. And that was especially true for people at high risk. This trial really shook things up and changed how we think about blood pressure targets.
So it pushed for more aggressive treatment in certain cases.
Exactly. And then there was the ALL-HAT study. That one compared different types of blood pressure meds head-to-head. And it showed that thiazide diuretics, those are kind of old-school meds. They were just as effective as newer, more expensive drugs.
So sometimes the simpler solution is just as good?
Yep. And then there was ACCORD, which looked at blood pressure control in people with diabetes. It showed that tight blood pressure control is super important, but going too low didn't actually provide any extra benefit, and it might even increase the risk of certain complications.
So it's about finding that sweet spot.
Exactly. Now, along with those three, there are 7 other important trials that the guide mentions. HEP, that looked at systolic hypertension in elderly folks. HET, that studied the optimal diastolic blood pressure target. ASCOT BPLA, which compared 2 different blood pressure medication regimens. FEVER, which looked at adding a calcium channel blocker to a thiazide diuretic. HYVE, that studied hypertension in people 80 and older. Pathway 2, which focused on resistant hypertension. And STEP, which looked at intensive blood pressure control in elderly folks from China.
Wow, that's a lot of research.
It is. But all of these trials have really moved the needle forward in how we understand and treat hypertension. They've helped us refine our targets, figure out which meds work best, and understand the importance of combination therapy and personalized treatment plans.
It's amazing how much progress has been made.
It is, and it's all thanks to those dedicated researchers and clinicians out there who are working hard to improve the lives of people with hypertension.
For sure. Now, the guide also gets into the different classes of recommendations that are used in hypertension treatment.
Right. These recommendations are all based on the scientific evidence, so they help doctors make the best decisions for their patients. It's like a hierarchy of evidence. Some recommendations are stronger than others.
So what are the different classes?
There are 4 main classes. Class I recommendations, those are the strongest. They're based on solid evidence from lots of well-designed studies. They're basically saying this intervention is really beneficial. You should do it in most cases.
So Class I recommendations are like the gold standard, backed by the best science.
Exactly. So, for example, making lifestyle changes, like following the DASH diet, coming back on salt, getting regular exercise, that's a Class I recommendation. Tons of evidence shows those things can really lower your blood pressure and reduce your risk.
Building a good foundation. What
Yeah.
about medication? Any Class I recommendations there?
Oh, yeah. Like if your systolic blood pressure is 140 or higher, or your diastolic is 90 or higher, starting medication is a Class I recommendation, no matter how old you are or what other health conditions you have. Because treating hypertension at those levels, it really makes a difference in preventing complications.
So when those numbers get high, it's time to bring in the big guns.
Yep. Now, the guide also mentions high normal blood pressure. That's like that in-between zone, right? Is starting meds a Class I recommendation for folks in that category too?
Good question.
Not for everyone, but it is for people who are considered high risk, like if you have diabetes or you've already had a heart attack or stroke.
So it depends on your individual risk factors.
Exactly. For people who aren't high risk, lifestyle changes are usually the first step for high normal blood pressure.
Which makes sense. And those lifestyle changes like the DASH diet, exercise, stress management, those are all Class I recommendations, right?
Absolutely.
Uh-huh.
Now, when it comes to specific medications, the guide generally says that those first-line agents, the ACE inhibitors, ARBs, CCTs, and thiazide diuretics, those are good starting points for most people. But the best choice, that really depends on each individual. Their other health conditions, potential side effects, cost, all that.
Right. It's personalized medicine.
It is. And the guide also gives a strong recommendation for using combination therapy right from the start. So starting with 2 or more medications, usually at lower doses.
Because that can be more effective than just using one drug at a higher dose.
Exactly. And there are a few combos that have really good evidence behind them, like an ACE inhibitor or ARB with a CCB, or an ACE inhibitor or ARB with a thiazide diuretic.
So you're basically hitting the problem from multiple angles.
Yeah. Now let's talk targets. What numbers are we aiming for when we're treating hypertension?
Right. Because lowering blood pressure is the goal, but how low do you want to go?
The guide sticks with the current guidelines, which recommend a target of less than 30/80. For most people, that is.
But, like we talked about before, there are exceptions.
There are. Like for older folks, sometimes a target of 130 to 139 over 70 to 79 is okay, as long as they're not having any side effects from it. You don't want to push it too low and cause more problems.
Right, finding that balance is key. And for folks with diabetes or chronic kidney disease,
Yeah,
those lower targets are usually more important.
exactly. Got to protect those organs. Okay, what about resistant hypertension? What are the recommendations when the meds just aren't cutting it?
That's the tough one.
It is. First things first, rule out pseudo-resistance. Make absolutely sure it's truly resistant hypertension. Then really hammer home those lifestyle changes. DASH diet, sodium restriction, weight management, regular exercise, all that good stuff. It's super important for everyone, but even more so when your blood pressure is hard to control.
Got it. So double down on those healthy habits.
Exactly. And then optimize those medications. You might need to add a 4th drug.
And that's a class IA recommendation, right?
It is. Good evidence to support it. But if MRAs aren't a good option, then you might consider other meds like alpha blockers or centrally acting agents. But those are class I, so the evidence isn't quite as strong.
So proceed with caution.
Yeah. And for really tricky cases, it's a good idea to get a referral to a hypertension specialist.
Someone who's seen it all and knows all the tricks.
Exactly. Now, the guide also talks about specific recommendations for certain groups, like folks with diabetes, chronic kidney disease, older adults, pregnant women. We've covered a lot of that already, but is there anything else you want to highlight?
I think we've hit the major points.
Sounds good.
Wow, we really went deep today. From the basics of blood pressure to all the complexities of diagnosis, treatment, special considerations, even the research behind it all. I feel like we've covered it all.
I think so.
Yeah.
And a big shout out to London Heartbeats Academy for giving us this amazing medical guide. We wouldn't have been able to do this deep dive without them. They've really gone above and beyond to make this information accessible to everyone.
Absolutely. And I know our listeners are feeling much more informed and empowered now. They have the knowledge they need to take control of their blood pressure and their health.
That's what it's all about. So, as we wrap up, we want to leave you with this. Knowledge is power. You have the power to make healthy choices, to advocate for yourself, to work with your doctor to find the best solutions.
And remember, if you have any concerns about your blood pressure, don't hesitate to reach out to your healthcare provider. They're your partners in this journey.
They are.
And before we go, we want to thank London Heartbeats Z Academy one more time. And they have some exciting news. They're now on social media, making it even easier for you to stay connected and learn more.
Yep. You can find them on Facebook, Instagram, Spotify, and YouTube.
So search for London Heartbeats Z Academy on your favorite platforms and give them a follow. They're constantly sharing great tips, insights, and resources to help you live a healthier life. And it's all free.
Free and valuable. You don't want to miss out.
So until next time, stay curious, stay informed, and stay well.